Here is Wyatt, who joined HealthInsight in October of 2008, and he's currently the Vice President of Utah Operations. Wyatt has also worked as the Health IT Operations Director of Utah before he was Vice President, and he was the manager of the Utah Health Information Technology Regional Extension Center team. He also worked as a project coordinator on the Physician Office Quality and Technology team. Wyatt has a Master of Health Administration as well as a BA in Information Systems and Technology. Prior to joining HealthInsight, Mr. Packer was working as the Director of Data Integration Services for a software vendor in the telecommunications industry. And he's also worked as project manager for over 10 years. Wyatt.
Thank you, Heidi.
You're welcome. Thanks for being here.
Yes, please do clap. It makes me feel better, especially after following Christy. That's a tough act to follow. She is really good. I don't know if you heard in the introduction, I have a BA in Health IT, so I'll try not to bring that bad attitude to this setting, but I do have, every time I hear that, I think, I have a BA in Health IT, or in IT systems, so anyway, I'll try not to bring that. I do have a purpose today that I was told to cover, and I'll try to do that. My objectives is to provide an insight into the landscape of Health IT that we've touched on here, specifically in Utah, and then some expansion of that to some federal initiatives and things. Also to examine the gaps in technology and resources that currently exist around health information technology, and then to highlight progress and achievements that we've seen in the state. So we're going to try and cover those things. Mark Bennett, our CEO, this morning covered who is HealthInsight, so I won't go into too much detail, except you'll notice the emphasis there that we are a recognized leader in health information technology initiatives. It's been a part of our history, the recent history, but as well as going back even, I believe, starting in 2001, we jumped into the health IT arena. So we'll touch on some of that. He also touched on the relationships that are critical to see an improvement in any system. When you're trying to change a system, it's not just one element. You focus on one element and then everything changes. You actually have to keep a focus across the broad elements, multiple elements within a system to basically rise the tide that rises all boats. You need to focus on rising all at the same time. And so you'll notice that there are some elements specific here, using HIT for care coordination, sharing clinical data across providers and care settings. Ultimately, to achieve the better outcomes, there's going to be elements of health IT intertwined. This was an early conceptual model of the beacon that Heidi just talked about, or sorry, Christy just talked about. But the element that at the foundation is health IT. If we're going to see an improvement in care delivery, in measuring and provider feedback, and in payment reform, ultimately for sustained quality and efficiency improvements, we have to have a foundation of health IT. And I'll talk about some of those elements. But ultimately, electronic health records and that clinical exchange of information are critical to the success of this effort to improve patient care. Mark used this to show how these elements play together, and I wanted to share a quote with you that I heard just last week from John Halamka, MD. He's the CIO of Beth Israel Deaconess Medical Center. He's also the co-chair of Health IT Standards Committee and a practicing ED physician. He and John Hoyt, who's the Executive VP of HIMSS Analytics, which is Health Information Management Systems group, they, in an article last week, said, real healthcare transformation that Americans universally agree we need is not possible without health IT. Investments in health IT are investments to improve the quality of patient care for Americans. So we need to involve health IT in the investments that undergird all of this effort to improve payment reform and delivery system redesign, and insurance reform, again, has to have that foundational element of health IT. So to give you a little bit of the history of HealthInsight, in 2001 and going through 2004, HealthInsight began working in this arena under the Doctor's Office Quality Information Technology Initiative, which was a Medicare-funded initiative to begin to help providers adopt electronic health records. This had one element I wanted to touch on with that. HealthInsight began that effort and it continued that effort actually up until 2008 with some additional funding through the Utah Medical Association and the Department of Health. But through that effort, we went out to hundreds of physician offices across the state and we interviewed them. We figured out, so the ones that already had a system, and there were very few at the time, we interviewed them to find out, what was your experience? Was this worth it? And then we took that learning out to the rest of the providers that did not yet have an electronic health record system, and we helped them look at, are you really ready to make this jump, to make this change in your system? And there was quite a few that we told, you're not ready for this change. Hold on. You need to do some preliminary steps before you go that direction. And so that effort, ultimately, we helped support over 400 practices in EHR adoption. But again, quite a few that just weren't ready for that change yet. But then we continued some of that efforts through a Medicare QIO physician office and care transitions effort, or an additional initiative through Medicare, where they said, okay, you helped adoption of EHR in many clinics. Now go to those clinics and help us understand at what level they're documenting screenings for cancer, both breast and colorectal cancer, as well as immunizations, flu and pneumonia vaccines. And so we went into multiple clinics. I believe we worked with 60 clinics in that effort. And we looked at how well are you documenting the care that's being provided. And that's where it really demonstrated that they were providing the care. They could show in their notes, in their typed notes, or on a paper record that they had done screenings, helped support patient screenings, as well as immunizations. But when you tried to pull the data out of discrete data elements within the EHR systems, the data was not there. And so that effort really helped to improve their methods for documentation in an electronic health record. It's not just a filing cabinet where you scan paper records and then you have access to them whenever you want. It's about capturing the A1C levels that Christy showed. It's about capturing the screenings for cancer and the immunizations that are done in the office or elsewhere, so that the provider at the point of care knows what's been done to that patient, that they've had this screening, they don't need to go and have additional tests, that they've already had a vaccine 10 years ago for the flu, or sorry, for the pneumovax. And so it just helped us to recognize that gap in documentation versus care. Excellent timing. Then shortly after that was the Regional Extension Center effort. Christy talked about the timing. It came out of the, and I'll talk a little bit more about this later, but it came out of the American Recovery and Reinvestment Act, funds that would help support providers in electronic health record adoption, and I'll talk quite a bit about meaningful use and what that means. And then the Beacon Community Program, a demonstration of the impact of advanced health IT implementations on care management for diabetic patients specifically.
Is Utah pretty much ahead of everybody else in this, or it seems like this is pretty small numbers that we're talking about?
So, yes, so some of those numbers I was throwing out were, again, back early 2000s. I'm going to give you some, where does Utah stand now? But in a general sense, Utah has been seen over the last 4 or 5 years as a leader in health IT adoption. And I'll give you some statistics a little bit later on. We're probably still upper quartile in most things, but there are some areas that we're unfortunately starting to see us fall a little bit behind, and I'll talk about some of those things as well, what the gaps are still that we need to address. So great question, and I'll hit it even more here in a minute. In an effort to share what we had learned and combined with the Department of Health, the local health department association, and UHIN, the Health Information Network, we went out across the state to share information about where you are at as a community. So we took this, it's called the eHealthy Community Initiative, and we were looking at health IT adoption in regions within the state, and they were tied to the 12 health districts. So we went to each of those health districts. So for example, if you live in Layton, where I live, that's the Davis County Health District. We went to Davis County, we took information about that community, so to show them what percentage of providers in Davis County have adopted an electronic health record. How many are connected to the Health Information Exchange? How many are e-prescribing, utilizing that technology to improve care? So we went and we held these community events in an effort to inform and educate, and really to get the discussion happening in their local areas, to talk to their neighbor, to figure out as a provider who's using electronic health records. If they had the desire, after the lab came in, to share that with the specialist, so a primary care provider is sending their patient to a specialist, they would know that that specialist is on an electronic system, and they could make those connections to share that information rather than having to fax or send it by courier. So really just to get those discussions happening. What we did to share that information was we put together these community profiles. And it really is a snapshot of their health IT adoption in that community. I'm going to give you an example here. This is Weber Morgan Health District, and this was back the beginning, actually the end of 2011 is the data that you're seeing here. But really it's looking at, and you probably can't even see it real well, but electronic health record adoption is that top blue section, and it's broken out by type of practice. The total number in that community, how many are on an EHR, and then that represents an adoption rate, and then the state average. As you can see, that hospitals, all of the hospitals in Weber County had adopted an electronic health record. Statewide, we're at about 70% were at that time. We've gone up just slightly with the hospitals. But you can see, so they were able to compare how well they were doing as a community against the state average. So not only knowing how they were doing, but how are they faring against the rest of the state. And then we looked at clinical health information exchange participation, so the CHI and making those connections. This one is just utilizing the Regional Extension Center or working towards meaningful use of an electronic health record. Meaningful use EHR incentive attestations, so how many in our communities had already moved to a more efficient use of their EHR system. And again, I'll talk about that later. E-prescribing, again, how many are utilizing the electronic sending of prescriptions to the pharmacy, minimizing handwritten errors and things like that. And then patient consent, the collecting of consent so that a patient's record gets into the CHI and is available to their providers. So those are some things that we were looking at, and again, this is a demonstration of those providers, those systems, those clinics that had done these things to kind of highlight that they had made that investment into health IT and let their neighbors know that they were there. Did the same thing with those other elements, showing who in that community had implemented and adopted EHRs and HIT. So, a continuation of that effort, that was a short duration. I think it lasted 1 year, and we went once to all of those 12 health districts. Well, what HealthInsight then took upon ourselves was, in conjunction with our Medicare quality improvement work and the Beacon effort, as we said, excuse me, we need this discussion to continue. This was a one-time thing. We need to continue to provide information and data and learning to these communities so they can continue to progress. So the Health IT Learning and Action Network was really an invitation to all providers in the state to attend events. We've had 2 in-person events, two events that then went to additional regional areas. And then we are doing webinars as well to help provide information out to the communities. And we've got some focused on patient engagement, clinical decision support, clinical quality improvement, population health. So looking at all of these different areas across the state and helping to educate and inform our providers. Here is an example of some calendar of events that we have upcoming. Health IT Privacy and Security webinar coming up in June. Patient-Centered Medical Home webinar in July, and then we have a continuation till the end of the year with PQRS, or the Physician Quality Reporting System, Stage 2 Meaningful Use, patient portals, how to implement those, and then the Physician Office Quality Award celebration, recognizing providers in our states that are doing these things. So that's just a continuation of those efforts to really help support the communities in EHR adoption, in the use of HIT. Any questions to that point?
Can you, is this patient portal webinar, like with IT, like that, does it allow the patient to be able to go in and tap in and put in questions or fill out questionnaires on themselves or their family?
Great question. So typically, a patient portal is provided by the clinic or the hospital or the system that you are a patient within. It's giving you access to your patient record. They determine the elements that they're going to activate. So in one physician office, you might have access to just scheduling appointments and seeing a very basic summary of your care. Another clinic might give you full access where you can see all of your lab data, where you can interact with your provider via secure messaging and be able to provide information. And that would be the ideal, is rather than going into a clinic and filling out your medical history and your family history and all those things, you could go onto your patient portal and provide all of that information to your doctor before you even go in, so that saves you time and them time.
At work they have things like that they want us to fill out at work. I don't feel comfortable doing that at work, and I don't know what they're going to share with my employer, etc.
Ah, okay.
But with my doctor, I've already given them that confidence.
Yep.
But I haven't had until maybe now that type of access.
Right. So yeah, you'll see a patient portal. So I'm on United Healthcare's insurance, so I can go in and I can see all of the claims against my insurance. I can document some things there. But then I have with Intermountain, who's my primary care provider, I have access to my patient portal where I can see my lab results and I can see all of that information that's not going to the insurance company necessarily. They're kind of the same, Intermountain. Well, if I was with Select Health, anyway. But yes, it depends on what patient portal you're referring to. When it's directly from your provider system, so if they have an EHR, they'll typically be able to offer a patient portal to their patients. So that just depends on your provider, though, and if they've done that. So, okay, good question. Any other questions before we continue? Okay. Well, let's jump in now. I want to talk about some of the gaps in technology, training, and resources that we've seen. So, excuse me, I'm going to talk about meaningful use in more detail and how we feel that meaningful use is really helping to close a gap in health IT. And then we'll talk about some health information exchange gaps, some privacy and security gaps or risks, and then how staff and provider training is critical to bridging some of these gaps. First of all, it's important to understand, as if you've had experience in the arena of project management, you would know what your gaps are or your challenges are before you even go in, so that you can develop a plan to fill those gaps or to overcome those challenges. Health IT is no different. It has its challenges in three areas that I've highlighted here: financial, technical, and organizational or cultural change. And and you can see some of the examples there. Really, in a broad perspective, it's understanding that there are challenges to go through this process of adopting health IT. But knowing the challenges gives you an advantage, gives you the ability to work against those challenges or with those challenges. I remember growing up, I watched G.I. Joe, and at the end, what did they always say? Did you ever watch the cartoon G.I. Joe? Well, it says at the end that, "And now I know, and knowing is half the battle." I could have done that with the cool music and stuff, but anyway, knowing our challenges helps us as we go into any given project, and it's no different with health IT. So one of the first things on the financial perspective is recognizing that there's a lot of cost to adopting health IT. Well, meaningful use was an effort by the government to incentivize providers against that cost, to say, if you'll invest in health IT, we'll give you some incentives, some dollars to support that effort, and through that you'll find other efficiencies, and you'll be able to find the ROI through the use of health IT. And so it was under the Medicare program up to $44,000 over 5 years, or under Medicaid $63,750 over 6 years. And this money is going to, as an EHR incentive, but they've termed the use of EHRs as meaningful use, or using an electronic health record system in a way that improves patient care. Doing that, there's three things in a broader perspective. It's using a certified EHR technology in a meaningful manner. EHR, or meaningful use, opened up a whole new arena where now EHRs have to be certified to a certain level of functionality so that a provider can get meaningful use. If that's not an incentive to improve the systems and get them at least to a very minimum level, then I don't know what is. Because now it's the end user saying, I have to have your system do these things or I won't pay you for that. They won't get their $44,000 if they're not able to use a system that can help them get there. Let's see, it's exchanging health information to improve the quality of care, and it's reporting on clinical quality measures. So things like how well are your patients doing on their labs that show their diabetes is in control, or their hypertension is in control, as the clinical quality measures. So when meaningful use first came out, there was mass panic. There was fear of sheer anarchy, wholesale destruction, complete annihilation. These were some likely scenarios that came to the forefront. This was back in 2010, and it was funny but scary at the same time back when this little cartoon came out. But now, having 3 years, 2.5 years under our belt, it really is an understanding of meaningful use is raising the bar. It's rising the tide of all HIT boats to improve care. So none of these things really have happened. I think we've made it out of that concern time. Really meaningful use is about 5 key priority areas: improving quality, safety, efficiency, and reducing health disparities, engaging patients and their families in their own care, improving care coordination across the provider spectrum, improving population and public health, and then ensuring adequate privacy and security protections for PHI. Conceptually, meaningful use is about starting small with capturing data and setting up mechanisms to share data. But the future is really about improving health outcomes for patients and advancing clinical processes. So there's some dates up here. It all started in 2011, was the first year that a provider could receive incentive payments. The next stage will start next year. So right now they're working through stage 1. Stage 2 will be 2014 as a beginning period, and stage 3 in 2016. So these cartoons, again, were just kind of to lighten the mood a little bit, to say, are doctors or their administrators swimming after these hooks that will give them the incentive, but then we'll hook them in? That was some of the fear. Also, it's important to understand that federal incentives, whenever money comes from the government, there's a carrot that they put out there to go after, but there ultimately will be penalties if you're not meeting these requirements, and then that's when the stick comes in. Specifically, the incentives are available now. If they're not doing meaningful use by 2015, then there are penalties up to 3% decrease in Medicare reimbursement payments to physicians. So again, now is the time, if you work in a clinic, to begin to utilize electronic health records, offset some of the costs that you incur with this incentives, offset some of the costs with incentives for that investment that you're making before it will be required, and you've missed out on some of the incentives to offset those costs. This is just a quick look at the incentives. I mentioned up to $44,000 over 5 years. These go down, so in 2012 they still could receive the maximum. This year, if this is a physician's first year, they lose out on some of the incentives. 2014 it's down to $24,000, and again in 2015 there's no longer an incentive, and they'll incur some penalties there. Medicaid is slightly different in that there isn't the same timeline requirements. They can start anywhere between 2011 and 2016 and still receive the total maximum amount of $63,750. But this requires a 30% patient volume attributable to Medicaid patients. So this is taking care of the low-income population and providing care, where a physician, they get less reimbursement through Medicaid, and so the incentive's a little bit higher on the offset. Okay. Synopsis of meaningful use. There's a lot to meaningful use. In fact, the document was 864 pages that explained what meaningful use was. I didn't read the whole thing, but I read the majority of it. I skimmed over some parts. But really what it is Stage 1 and Stage 2 have been defined. Stage 3 has not yet been finalized. But Stage 1 was a total of 20 measures, 15 required. They call them core measures. And then pick 5 out of 10 of a menu set of measures. Stage 2 just added 2 core measures and then shifted to 3 out of 6 menu measure objectives. So these are elements that they have to do, demonstrating that they're using their electronic health record system in a certain way. It's like capturing smoking status or demographic information about a patient. It's capturing those elements within the electronic health record system. I won't spend too much time here. I think we've talked a little bit about this, but basically the Regional Extension Center program was funding $6.7 million from ONC, the Office of National Coordinator, and it really is to support providers in adopting electronic health records and implementing meaningful use. We had a 4-year time frame to do that. We're in the final year, ending in January. And I'll show you some things that we've been able to do in that time frame. We do provide general education and outreach to all providers in the state. They're put up on our website. These are tools and resources. We'll go into a clinic and tell them about meaningful use, kind of get them started. And education, again, through the seminars and webinars. If a provider's office, after knowing about meaningful use and what it entails, needs assistance, then we can provide that direct technical assistance to primary care clinics at no cost to them. And that, again, gets into helping them adopt an electronic record system, getting to meaningful use, and understanding privacy and security and what that is. So what we've been able to accomplish, and this is through the end of March, is our goal was 1,463 providers. That was just a number that they threw out for us, and we agreed to. We've met 100% of sign-ups. I apologize, that's a little small. Signing up physicians was the first milestone, so we had to find those that really needed assistance and get them signed up. We did that. Milestone 2 is about the EHR adoption, helping them get onto an electronic record, and we met that. Actually, when we started this, the majority of Utah providers were already on an electronic system, so we had an advantage. This is by state. Nevada, however, was just the opposite. They were very low in electronic health record system adoption. So that's where most of our work went in Nevada. Here in Utah, it's been all about meaningful use. And you can see we've met, actually right now we're at about 50% of our goal. So we're about halfway there, which there was a lot of work to even get to meaningful use. So we're glad to see that going up. But we have about 8.5 months now to get the remaining providers up to meaningful use. So again, if you work in a clinic that's not yet at meaningful use, we'd love to help you get there and quickly. So for Utah specifically, 1,000 providers is what we're assisting in this process, and that's about 180 practices and hospitals. And the focus really is primary care providers from 1 to 10 physicians, the smaller practices in our state. The Intermountains, excuse me, some of the HCA systems, that's not what this funding was about. It was focused on helping support those that wouldn't be able to get there on their own. So we've helped to this point over 560 providers get to meaningful use. That's almost 120 practices and hospitals. And there, like I said, there are still slots available to use this funding to help support physicians in our state get to meaningful use and use an electronic health record system. Our effort is really about minimizing the valley of despair. I don't know if you've heard of this term. I don't know if it's a general project management term, but specific to health IT, it's really looking at, you want to try and minimize that point at which when you adopt a new system, you will lose productivity. That's just the reality. When you go to an electronic health record as a provider, you will lose productivity and efficiency because it's a new system. It's all new. It's new workflows and everything. What we want to do is minimize that, because the possible future is you just barely, slowly start to climb out. If you do nothing except turn on an EHR system and say, I'm going to try and use this, it will take doctors years before they get back up to their productivity before they started. Excuse me. However, if they have support and they understand what they're getting into, we can get to a preferred future that consists of good choices, good management of the project and the process to where they're back up on their feet and further than where they were when they started. So that's what we're about in these offices. How we do that, it's really all about managing the change. It's helping them recognize that it's a lot more than flipping the switch of an electronic system. Your staff, from the front desk all the way back to the billing office, needs to understand and change their processes to be involved in an electronic world. And it takes a lot of work to do that. What we do is we help them establish an EHR and meaningful use team to start. And then we start looking at things. If they're on an EHR system, then let's jump in and start looking at your data. Are you capturing the elements of meaningful use within a discrete data field? Is it reportable data that we can pull out? And then drive to the gaps. Of those 20 measures, if you remember, there's 20 measures they have to pass. We can run a report that tells them of the 20, you're meeting 15. And then we really focus on building a timeline and a gap or a plan against those 5 measures that they're not yet meeting. For the most part, they're usually not meeting any of them without some tweaks and some adjustments, but it's about developing a plan to help them get to their end goal. Implementing best practices, helping them recognize that there are clinics out there using your same system and they're succeeding. What are they doing to succeed? And we can bring that to them, because as a single physician office, they don't see what the rest of the world is doing. As a support system for over 200 practices in the state, we see what's going on and we can bring those best practices to them. And then really it's about PDSA cycles. This is a life cycle outpatient system improvement. It starts with assessment. It starts with knowing where they're at, and then those report cards or those reports that help them understand where they're at and where they need to get to. And then building and developing workflows, processes, and policies that they need to make adjustments to really be able to do well with this. And then it's about putting in place the implementation of those policies and procedures, of the standard operating procedures in their clinic that will make them successful with using the system. And it's iterative. It's focus on one area, make that better, move to the next, and continually monitoring the reports to ensure that they're making improvements across the spectrum. So some lessons learned. Excuse me. From stage 1 meaningful use. Do start early, tracking and monitoring the meaningful use measures. Do consider other initiatives. Meaningful use is not a siloed project. There are other elements. There's physician quality reporting system, medical home. It's understanding how all of these things play and tie together. It is recognizing and getting an EHR champion, specifically a physician in their clinic, or if they don't have that person, getting somebody that can come in and help support them at the physician level. Clinic culture is really driven by, in these small clinics, small offices, by a physician. And so it's having that champion. Incorporating goals in their training around quality. Recognizing that, again, it's not about using the electronic health record. It's about having the ability to document and report on the quality of care that they're providing to their patients. And then do question the data. When you get that first report and it says you're not doing anything right, well, where is the data coming from? What elements within your EHR system need to go in which data fields so they're reportable? The no's, don't wait. We talked about incentives decreasing and objectives taking time. Don't depend on vendors. Too often they wait and they say, oh, my vendor will do that. When we were in our recruitment phase, we spoke with over 100 practices that said, oh yeah, our system is certified and our vendor is going to get us there. And then 6 months down the road, we recontacted them and asked, so how's meaningful use coming? Are you there yet? No. Are you guys still available? Because they just assumed that they had a certified system that would get them there. And so, again, don't depend on the EHR vendor, and not assuming that privacy and security issues are handled by your vendor. And I'll talk about that here briefly. But barriers in meeting meaningful use. Failure to provide patient summaries. I won't get into these unless any of you are clinical or have clinics. Okay, won't spend too much time here. Electronic exchange of information is one of the barriers to meaningful use, and I'll talk about that. Participating in PQRS and other, the e-prescribing helps support meaningful use. Vendor delays, workflow, or financial or resource-related delays. So health information exchange, I want to talk about now. So that was meaningful use. Health information exchange is about getting the information where it needs to be, secure clinical data, enhance collaboration, decision support, real-time data, and continuum of care to provide the knowledge to improve care and reduce costs. This is all about the CHI, the health information exchange. The problem is there's some significant barriers specific to Utah. Patient consent, that is the decision of the patient as to whether they want their data in the CHI and available to their providers or not. Well, Utah started, we're heading down the path of an opt-out, which meant the patient was in, their data would be there unless they signed something saying, I don't want my data there. At some point, our community, this is a community-led program, and at some point the community said, you know, we're so conservative here, let's take the approach that everyone is not in unless they tell us that they want to be. And that's that opt-in consent form that we were talking about. The challenge with that is, of 3 million today, approximately 3 million people in Utah, we only have about 500,000 consents after 3 or 4 years of significant education to the population saying, go get connected to the CHI, get your records in there. The funny thing is, of the 500,000 represents 90% of the people that have gone in and said what their wishes are, 90% of them, more than 90%, have said they want their records in. So we defaulted to the minimum or the most conservative, but the majority of people that have had the chance to say whether they want in or out, the vast majority want in. So it's really the challenge is about educating the public that this is even an option and how to go about connecting so they can get their records in. So that's a significant barrier. Vendor connections, the flow of data through from the EHR systems to the CHI has been a significant barrier. The EHR vendors are trying to connect to 50 plus, because there's at least one in each state, 50 plus, and I know actually the number is much greater than that. They have to try and make their connections to all of these different electronic or health information exchanges across the country. And so they're overwhelmed with all of that effort that has to go on in developing those connections. And that's been a significant barrier for us. And then provider and system adoption. Again, just letting the providers know that there's data there, that there's patients' records there, getting it into their workflow so it becomes a part of their process. We talked about the e-pulse form for EMS technicians. Same thing with the clinic. They need to know that this is an option. There's something they can go and find data about their patients and how to get that data into their system. Without that education, they may not be aware of it. Another gap within health IT adoption is around privacy and security of PHI in the electronic world. The HITECH Act of 2009 made it more stringent and added to the HIPAA Act of 1996. So HIPAA is about keeping your records secure and about allowing that transfer, secure transfer of information. HIPAA was really paper-based. They expanded it to an electronic world with HITECH Act in 2009. Meaningful use requires a risk assessment. So if they're getting to meaningful use, they're doing something. But really, there's three broad areas: physical, administrative, and technical, that cover everything from people, processes, policies, as you can see the list there, that is covered as part of privacy and security of ePHI. Well, most of our small clinic physician practices in the state have the deer in the headlight look, because this is a whole new realm for them. HIPAA, they knew that they had their HIPAA policy and procedure booklet, and they put it up on their shelf, and they could refer to that if they needed to. But the electronic world added a whole additional element for them. Ultimately, the physician practices are responsible to maintain those systems private and secure, and there's huge penalties. This is just two ends of two that happened recently, audits that happened. One was fined $100,000, small clinic. Another was fined $1.5 million. That was a multi-practice site, because they didn't have, or there were violations against the requirements for HITECH. So this is a big part of project management within a clinic that is being overlooked, unfortunately. And really, the cost to mitigate the risks are significantly lower than the potential costs of those violations. Again, it's an education piece for our providers. So I'm going to end on a couple of positives. So we talked about the gaps. Here's the positives. EHR adoption at a national perspective, I'll show you. Meaningful use attestations, e-prescribing progress in the state, and then you've heard about the beacon progress. This is a map of the country, and it shows, here is the adoption rates. It starts with red, is 16 to 27% electronic health record adoption. The blue, dark blue, is 40 to 61%. So that's all physician practices, office-based providers. You can see that Utah is the top tier. We have one of the highest EHR adoption rates in the country. And even, there was a report in the Annals of Family Medicine recently that put Utah at 94.9%, the highest rate of adoption among family physicians. So Utah is very advanced in the electronic health record adoption. Unfortunately, the larger systems are the ones that are higher. If we look at the independent physician practices, They're quite a bit lower than that. And primary care, however, is higher than specialty care. So some of that chronic conditions where they're having to go see a nephrologist if they have a kidney disease, unfortunately, if the specialist is not on an EHR, then we lose some of the value of HIT adoption in our state. So, but that's one positive, is how high we are nationally ranked with EHR adoption. This just shows across our state, this is the EHR incentives, so those that have met meaningful use requirements. Obviously, this is just numbers, total number of providers. So our biggest areas are along the Wasatch Front and then St. George. Really, the important part here is that these incentives are real, they're being paid out, and it's funding, it's incentives coming to our state that help to rise the investment in health IT that does benefit all of us as patients and consumers of health care. But it shows here 1,831 paid out between Medicare and Medicaid for provider level. That's almost 32 million. And then total, so you add in hospitals, we're at 65 million. 13.5 billion of the total investment that was put out there by the American Recovery and Reinvestment Act have been paid out. So money's flowing, it's helping to support this investment in health IT. Another positive spot is the Utah Wired prescribers. Back in Q3 of 2011, we were down at just over 1,500, and now we're up to close to 4,500 providers on the SureScripts network, or they are really the transactional piece for prescriptions electronically. This shows back in Q3 we were one of the lowest in the country with e-prescribing. At 5.7% of all prescriptions sent were electronic. We're now up to above 40%, and our trajectory of ERX utilization. We switched data sets. Medco was providing us with some data back early 2011 and 2012. Now we're on SureScripts data, which is the blue. So it's just a switch of two data sets. But ultimately, we've made great progress on e-prescription in the state. So I've taken all of my time plus some of the Q&A, which is good because if I get asked questions I don't know the answers to, I get nervous. So, but I will open it up. Do you have any questions that we haven't already talked about?
I've got a few questions.
Okay.
First of all, you talked about using certified EHR systems.
Yes.
There must be certification agencies
Mm-hmm.
that were developed?
Yes, excellent. So the Office of National Coordinator under HHS, Health and Human Services, designated agencies that would certify electronic health records. There's 5 agencies that certify, so 5 different agencies, and there have been over 1,000 systems that have been certified.
And can you achieve meaningful use without using a certified system?
Nope.
No,
You have to have a certified system.
Even if the uncertified system meets all the 15 or 20 criteria.
Correct. Yep. If they don't go through the process of becoming certified, then the provider can't receive their incentive payment.
Can I ask you another question?
Please.
So once meaningful use is achieved or met, what's the incentive to continue to meet that? I mean, the most obvious thing I think is the security risk assessment. This is something that needs to be done on an ongoing basis. Otherwise, you drift away from having a secure system. So is there an incentive for organizations to continue?
So the hope was, remember that this is over a 5-year period, there's incentives paid out. So they hoped that across that 5 years, that the practice themselves would find those efficiencies gained, they would find those internal incentives to continue to do these things. And what we found, we went to clinics, and one clinic administrator told us, we were reviewing his records, and we said, one of the requirements of meaningful use is that they send a reminder to their patients that they're due for a screening or something. This administrator jumped on that, and he ultimately then started sending reminders to all of his patients that were overdue for tests, for screenings, that they hadn't had their LDL control and needed to come back in. So they went on the offensive. Rather than being defensive and when the patient comes then saying, oh, you're overdue for this, or you need to have this done. They went on the offensive, and they've improved their patients' quality of reporting to show that now their diabetic patients are getting the care that they need. And that, in the current system of payment, that drives their revenue up. The more they see their patients, the more they get paid. Unfortunately, that's not always the best thing, as Christy talked about. Ultimately, payment reform will help us so that they'll get paid based on the quality of care given to the patient. But right now, that administrator found ways that he could do meaningful use and improve his bottom line at the same time. So they're hoping that their incentives will be found through the use of the system over time. So.
One more?
Uh-huh.
Okay. The fines you mentioned, 100K or up to 1.5 million, it's a pretty big disincentive in moving to this sort of system. 44,000 versus the risk of an awfully big fine, if I'm just using paper records, for instance.
Sure. Good point.
Are there companies that have an industry, perhaps, that's been born of folks who will do the security risk assessment and then assume the liability?
That's a great question. I know the answer to, is there somebody there that can do that? The answer is yes. I don't know. I do know that insurance has expanded to be able to provide that insurance to a provider, that if they get audited and they don't pass, or if they have a breach, that insurance will cover that for them. So I know that piece is expanded. I'm not aware of individuals or companies that come in and assume liability in behalf of the provider, or if that's even legal, I guess. That's a good question. But ultimately, if a provider on Medicare, a 3% decrease in their reimbursement adds up very quickly for a specialist seeing lots of Medicare patients. So it's taking the bigger picture of how is this going to affect you if you don't do it, and then if you don't do it, or you go on to an electronic world, but then you get fined, the offset there. So we are out of time. Any other questions that I can sneak in before Christy pulls me? I do. Yes, I'll share those around. Anything else? Okay.
No, thanks, Wyatt.
Thank you. Yeah.